questions anonymously or not anonymously. So and feel free to type in any questions as you go or as we go along. We'll try to answer some of them here and there, and also hopefully save some time at the end to answer some questions as well. I'm hoping we're going to have some polling questions throughout, and those answers will be recorded anonymously. So if you see a poll come up, I hope that you'll answer that so we can kind of gauge who's in the audience and some other thoughts or opinions that you may have about things. Okay, so just an overview of the topics that we're going to cover. As I said, we'll overview some of the uses and effectiveness of segregation, reviewing some of the best practices in correctional treatment, introduction and orientation to the Stepping Up, Stepping Out program, which this is probably a good time to disclose that, again, Bob and I are primary developers of this program, and so we have a financial interest to disclose, although I don't know about you, Bob, but they may have lost my address. I don't think I've gotten any checks. Oh yeah. So, but just to be transparent about that. And then we'll also go into some recommendations for program evaluation and just some final remarks. And again, hopefully have some time to get into more detail with your questions.
One thing I would add, if I could jump in, Ashley, is that's our planned topics. But if you could take 10 seconds and type into the chat if there's anything else, or if you could just communicate very quickly and briefly your expectations or what you would like to get out of this, we will try to make sure we tailor our discussion to your interests as much as we can. Depending on, there's 180 participants already, but so depending on how many of you respond, we may not get to everything, but it would be helpful to us to know what you're hoping to get out of it today. So if you could include that in the chat, we would appreciate that.
Okay, thanks, Bob. So you'll keep track of those answers.
Yes.
Okay. All right. So before we get into what I have been calling the great seg debate, I'm going to try one of these polling questions and ask how many of you have ever, including currently, worked in a restrictive setting, housing setting, or with clients in these settings. I'll give you all a moment to click yes or no there. All right, so it looks like about 85% or so of you are saying yes, that you have worked in these settings, and about 17% are saying that they have not worked in those settings or have not yet worked in those settings. So good, we have a good group of people who have had some experience, so it'll be helpful if you can, again, engage with us through the chat or the question and answer box so that we can, better target or speak to some of the experiences that you may have had. I see some other people putting in that not working in prisons, but high security forensic hospitals and other sorts of settings where there's higher security locations. I'm going to end that poll there. All right, I always like to start with a little bit of history about the practice of segregation, because I think a lot of people don't really delve into this or don't have an idea about where segregation really even came from or why we started using it in the first place. And I think what often comes as a surprise to a lot of people is that it began as a criminal justice reform effort in the 1700s, and it was meant to be a more humane, if you can believe it, practice to counter what was an eye for an eye mentality for punishment, right? So you stole a piece of fruit from the market and they chopped your hand off or whatever, or they put you into public humiliation and torture and things like that. So it was a more humane way of punishing individuals who had committed crimes. And so it was based on so these Quaker ideals, which was a group of an English religious sect that came over to the United States. And it was based on these ideals that essentially talking and social interaction were not very helpful, and that the way to repent for your sins and for your crimes was to rely on the Bible and to participate in manual labor. And so segregation was really or solitary confinement was really used to provide individuals with a quiet place for solitude, to think about the consequences of their behaviors, repent to God, seek forgiveness, and eventually emerge as a changed person. So with the exception of manual labor or maybe some spiritual guidance, there was not a lot of social interaction. As you are likely aware, things quickly turned to the other side of the pendulum, right? If any, does anybody recognize this structure? Some of you may, some of you may not. I personally am very interested in this prison. I just think the history of it is really, really neat and interesting. But this is an illustration of Eastern State Penitentiary, which is in now Philadelphia, Pennsylvania. And it was constructed in around the 1820s. And again, it was intended to sort of carry out these Quaker traditions of isolated repentance and build on what is now considered to be the first state-of-the-art prison structure. It cost a lot of money, actually, compared to, comparatively speaking. So it was about $800,000 to build this structure, which is close to about $20 million today. So this was kind of the first state-of-the-art prison and carrying forward this idea of segregation practices. And so with prison expansion, the incarceration pendulum again began to swing back in favor of punishment, and solitary confinement was quickly moved to a place where things were pretty grim, to say the least. So people were subjected to really dark, small, unclean rooms, little sensory stimulation, and things like that. And this is a quote from Charles Dickinson, who at the time kind of labeled the system as rigid, strict, hopeless, and cruel and wrong. So there was a lot of attention on this inhumane treatment of this once criminal justice reform, this once novel and more humane approach quickly turned to be somewhat inhumane. I thought this was interesting just to illustrate. This is actually what Eastern State Penitentiary looks like today. So you can, if you're interested in this sort of thing like I am, you can visit it, and it's a historical site, and you can see that the city of Philadelphia basically sprouted out around this prison. And if you're interested in Halloween stuff, they have a attraction in non-pandemic times where you can go and be spooked, I guess, terror behind the walls. I've been there, it's really fun. So anyway, so this is what Eastern State looks like today, and you can still visit it. So of course, segregation in the United States doesn't look quite the way it does or did back in the times of Eastern State, but they all generally have kind of the same features. So in a general sense, inmates are spending about 22 to 24 hours a day in their cell, sometimes alone. Sometimes they have a cellmate, not often. They'll get recreation time, some access to in-cell entertainment often, such as art therapy or radios, things like that. They can place medical or mental health calls. Typically, they take meals in their cells and things like that. So a lot of you may be familiar with this survey out of the Yale Law School that came out around 2014. And this is a national survey looking at the number of individuals who were in segregated housing. So of the 1.6 million people in prison, about 80 to 100,000 of them are in segregation or restricted housing settings across the country. So importantly, this number doesn't include local jails, juvenile facilities, and it didn't include military prisons. So it's likely a little bit of an underestimation as far as how many people are in restrictive housing settings. Another interesting point about this is the cost difference. So to maintain someone in the general population, it's costing prison systems on average of about $25,000 per year. And if you compare that to the average cost of holding someone in a segregated unit, it's about 3 times more expensive. So from an administrative standpoint and a budgetary standpoint, it's also really interesting to think about the needs to reduce the number of people in segregation for this reason as well. So we talked about some historical, structures of segregated housing. This is, some of you may work in institutions that are, depicting a similar presentation that this image is depicting, and this is a more modern day supermax facility, and this is more so what a segregation unit might look like. A lot of you likely recognize this individual. This is Khalif Browder. He was a 16-year-old who was picked up for allegedly stealing a backpack. He was sent to Rikers Island and was held in an isolation cell for nearly 3 years without ever even being convicted of a crime. So he was still in a pretrial phase and was being held in an isolation cell for quite a long period of time. Unfortunately, I'm sure many of you know the story and the outcome of this particular case, but things did not end well for Khalif. He ended up dying by suicide shortly after his release from Rikers Island. I'm sure everybody listening in now would agree that what happened to Khalif is unjust, unfair, and should not happen to any individual. And it's really these unthinkable events like what happened to Khalif that have caused solitary confinement or segregation to become a huge advocacy effort and has come under fire quite a bit. In 2016, some of you may remember that then President Obama issued a statement calling for the end to segregation, especially for kids and people with serious mental illnesses. And there's been a number of lawsuits involving state DOCs as well as the Federal Bureau of Prisons demanding more humane treatment for segregated inmates. But I think a lot of you, especially those working in these units, would agree that the issue of segregation is maybe not as clear cut as it might seem on the surface. And again, there are others, mostly those of you who are living in the reality of jails and prisons every day, who might feel a little bit differently about the use of segregation. And so I found this somewhat short clip. I may end up cutting it a little bit short, but it kind of shows some of the struggles with certain types of inmates and where prison officials and administrators might find segregation to be one of the few options that they have. I hope this works.
A vicious, relentless assault, all of it on surveillance video. Watch as a Brooklyn detention officer stood next to an open cell block. You can see a prisoner walk up a set of stairs before getting in the guard's face. More inmates came through the open block. All of a sudden, an inmate started to punch the guard over and over again, even putting him in a chokehold and throwing him down on the ground before throwing even more fists. The officer left lying there, not moving, that towering prisoner walking off.
He was beaten pretty bad. He's still in the hospital. He has a concussion.
A photo shows that guard's bruised and bloodied face as he lay in a hospital bed. Another guard was attacked on Rikers Island. The Correction Officers Benevolent Association says this is the third assault on one of their own in just 2 weeks, and they want the violence stopped.
It's time for Commissioner Brand to go, and it's time for Mayor de Blasio to do his job and give us back punitive segregation.
The union president spoke to the media Wednesday. He explained that without pulling troublemakers aside, attacks like this one will never stop.
When these inmates attack us and when they're violent, we're able to segregate them. We're able to move them away, keep them away from us, keep them away from the other inmates.
We asked Department of Correction Commissioner Cynthia Brand for an interview, but by Wednesday afternoon, she simply released a statement saying the department is doing what it can to keep officers safe. But that's not enough for the union, and until more is done, it tells us it'll continue to fight for these officers. Mark Liverman, CBS 2 News.
The union is also calling on the city to reinstate disciplinary sanctions. As for the inmates, the Department of Correction says they were rearrested.
So that may be a scene that some of you have seen before, maybe been, been witness to. Before we get any further, I wanted to kind of talk a little bit about terminology. There's a lot of different terms for restricted housing, segregation. So these are some that you may have heard before that you may use in your own facilities. Again, solitary confinement, segregation, restrictive housing, special housing units, seclusion, punitive or disciplinary segregation, administrative segregation, protective custody, special management, supermax. There's all kinds of terms, and if you use any terms that aren't up here, let us know. I'm always interested to hear how these units are labeled. So do they all mean the same thing? Are these just like interchangeable terms for the same type of unit? Not necessarily. It often depends on the setting, the purpose, the function of the placement. And so I'm going to go back here for a minute. For example, solitary confinement is often the term that's used more colloquially or in the public eye or by advocacy groups. Segregation and restrictive housing, for the purposes of this presentation, Bob and I are going to be using those terms more interchangeably. Administrative segregation tends to be more long-term segregation, known gang affiliates, people who are just frequent flyers, typical troublemakers. Punitive or disciplinary segregation tends to be shorter term and used specifically to sanction certain behaviors or certain actions that go against the prison policy. Protective custody, a lot of you are, I'm sure, familiar with that, is often similar environmental constraints, but people are placed in there for their own protection because they have some sort of vulnerability factor. So yes, they're not necessarily the same thing. Sometimes they differ depending, again, on the setting and purpose. But again, for the purposes of this talk, we'll be using segregation and restrictive housing pretty much interchangeably. So I'm going to turn it over to Bob. He's going to cover some of the different sides of the debates regarding the actual empirical research on the effects of placing individuals in these restrictive housing settings.
All right, thank you, Ashley. Before I get into the research here, I wanted to address a couple of the questions. I typed the response in the chat and also in the question form, but I don't know how you all necessarily received that. So one of the questions was, what is the reason for the increased cost of placement and segregation relative to general population? And the increased cost really boils down to security and medical costs. On the security side, for example, it's generally required by policy that there are more correctional officers per unit. The units typically have fewer inmates, but more correctional officers. If an inmate is going to be transported out of segregation, say to medical or an attorney visit or a family visit, it usually necessitates 2 to 3 correctional staff from other parts of the institution, not the unit correctional staff, to transport. So there's a lot of security resources that go into managing a segregation unit, and those resources accrue pretty significantly and quickly over the course of a year. And similar with medical staff will often come into the segregation unit, so there's lost productivity time for the transition from the medical unit walking to the segregation unit. There's also less efficiency in terms of seeing inmates in segregation. And so when you add up the added medical time relative to the number of inmates that can be seen in general population, the cost grows pretty substantially. There was another question, not in the chat, but in the Q&A forum, about has there been any studies looking at private institutions relative to state or federal institutions? And I believe that was from Stephen. That's an excellent question. And unfortunately, I'm not aware of any research of that nature. That data may be available out there, but I haven't seen it. So I'm not aware of that. So thank you for the questions. Appreciate that you're sending the questions now rather than waiting to the end. One of the things when doing trainings of this nature, it's always fun when we can actually have a dialogue. So we'll do as best we can creating a dialogue, even though it's mostly unidirectional, at least verbally, but keep sending questions as you have them, and we'll address those. So As Ashley
Before you
said,
get started, there's a polling question that I want to send out as well that I almost forgot about.
I did not forget. I was going there, but
Oh, you were? Okay.
yeah,
All
go
right.
ahead.
I'm surprised you remember.
See, now there needs to be a work on increased trust amongst presenters here, but we'll save that for another webinar. So as Ashley indicated, there's a lot of debate, if you will, about the effects of segregation. It's actually a very litigious issue. Prior to about 7-8 years ago, I really hadn't done much research with regard to issues facing inmates in segregation, but it was because of my involvement in a number of legal cases that I began to dive into and get involved in looking at the research. As I indicated earlier, I had previous clinical experience, about 1.5 years, providing clinical services in a supermax or a segregated housing unit. But only recently have I dived into what the research tells us and contributed to that body of research. And the primary question that comes up is, what is the effect of segregation? What is the effect on an inmate's mental and physical well-being when placing them in a segregation unit? So to that, we have a polling question to see what you think the effect is based on your experience or your assumptions if you haven't worked in segregation, what you think the effect of segregation placement will be on an inmate population. So Ashley, if you'll do the polling question.
Mm-hmm.
To what extent do you think restrictive or segregated housing causes significant psychological harm? No negative impacts, minimal negative impacts, moderate or significant, and we'll let you go ahead and respond. We'll give it about 10, 15 more seconds, and then Ashley, are we able to show the results?
I think you can see them. Can you not see them on the screen there?
No, I just see the poll.
Oh, with you don't see the bars there with the percentages?
No.
Okay, well then I'll share.
Yeah, others can't see it according to the chat. You have to launch and share it.
All right.
Thank you, Nathan. Thank you, Angela.
Sorry, I'm new to the polling feature. Okay, well, I'll read. It seems like the bars have stopped. So about 1% say no negative effects, 8% are minimal effects, 33% said moderate effects, and the majority, 58%, said there were significant negative effects.
Okay, so the majority of you would say that placing somebody in a segregated housing unit would significantly negatively impact their mental health well-being. Let's look and see what the data tells us. All right, so there's certainly a body of research that would suggest that it's really bad. Dr. Craig Haney, Dr. Stuart Grossian, and colleagues have published a number of papers that would suggest that placing somebody in segregation causes significant mental health harms, to include things like social withdrawal, depression, anxiety, more severe symptoms like psychosis, loss of sense of oneself, depersonalization, things of this nature. It's also been associated with poor post-release outcomes. So if you release somebody from a segregation unit directly into the community, so they release from prison directly from segregation, that they're going to fare poorer in the community than individuals that we release from general population. Okay, we also know, and the data is pretty clear, that inmates with mental illness are not only overrepresented in our criminal justice system at large. I assume we all are on the same page with that. And actually, you're attending to the chat, right? Mm-hmm. All right. So let me know if I need to address anything. We know that inmates with serious mental illness are overrepresented in corrections and criminal justice system at large. Well, it's also true in our segregation units. Okay. And there's been suggestions that inmates with mental illness do particularly poor when placed in segregation. In fact, many jurisdictions have moved to prohibit the long-term placement of inmates with serious mental illness in segregation. Right? Again, based on this body of work by, again, Dr. Craig Haney, Stuart Grossian, and some others, that suggest that segregation causes harm. In fact, some of these researchers have equated the use of segregation to torture, that it essentially causes such traumatic impairment that it's unlawful and needs to be disbanded completely.
So we have a question about whether the O'Keefe and Snell article distinguished between personality disorders and mental illnesses. I think that they did, but you would.
Yes. Yeah, O'Keefe and Snell were looking primarily at individuals with serious mental illness. So, in the DSM, we did away with Axis 1, Axis 2, but this study was in 2007. It would have been Axis 1 types of disorders. So it was looking at individuals with serious mental illness. All right. So there's that body of work, which from a research design perspective would be based primarily on studies that used qualitative or case study designs, less rigid, empirically oriented research methodologies. That's one body of research. And then we have a second body of research. Actually, there's an issue with some people being able to dial in. I had typed a response, but my response didn't address the issue. So if you can help that. There's a second body of research that has concluded that it may not be, it being the use of segregation, may not be as bad as we initially thought. First off, the body of research would suggest that the use of segregation actually works for its intended purpose, which is to manage problematic behaviors, that individuals that pose a threat to the institution, whether that be through security threats directly to the institution by way of escapes or threats to other individuals, be that staff or inmates, that the use of restrictive housing does work as a management strategy. There's also research that would suggest that when used in relatively brief periods of time, that any negative effects that do occur, they tend to be small and they tend to be temporary in nature, such that inmates adjust to the segregation placement, much like they would in a general prison population. Okay, and several researchers have concluded from this body of work that segregation in and of itself isn't really the primary issue. It's the culture of the institution and the nature of the relationship between staff, correctional staff, security staff, and the inmates placed in the restrictive housing unit. Okay, so we have these two competing bodies of research, both of which contain compelling information and certainly inform us about the effects of segregation, but they conclude on appearance, they conclude very different things. So the next step was to try to make sense of this body of work. And one thing that we have to account for when looking at the effects of segregation, and quite frankly, from my perspective, an area of study that we haven't spent enough time on is contextual factors, right? Again, I just mentioned the issue of the relationship between correctional officer staff. There's also contextual factors related to the conditions of confinement. And so I think this picture here depicts some of the concerns we have when looking at individuals who experience particularly negative outcomes or have negative reactions to segregation placement. What's the context within which they're placed during their segregation confinement? So these two cells, as you can imagine, I really don't need to put words to it, that although neither is ideal, none of us want to be confined in one of these cells for a significant period of time. One certainly seems to be less aversive than the other. The picture on the left, a more clean, sanitary, comfortable looking segregation cell versus the picture on the right, which is obviously older, well used, might be a good phrase for that one, and certainly less comfortable amenities, right? So we need to consider the context of the segregation placement. Okay. So the next step was to try to address, with these two competing bodies of research, was to try to address a number of questions. And the first of which was, if we ran a well-controlled study that tried to control for some relevant variables and looked longitudinally at the effects of segregation, what would we get? And that's where O'Keefe and colleagues in 2010 come in. This was a federally funded study, a study funded by the National Institute of Justice, and it's frequently referred to as the Colorado study because it occurred in the Colorado Department of Corrections. I and others have referred to this as the gold standard because, from my perspective, this study was the most sophisticated study completed, still currently, in my opinion, to look at the effects of segregation. What they did was they had 247 individuals that they polled from segregation units, the general prison population, and a general psychiatric facility. So they had three groups. The segregation group, which was the target group, the experimental group, relative to two other non-segregated populations, general prison population and inmates with serious mental illness in psychiatric facilities. And as I said, this was a longitudinal study in that they tested them over the course of a year with multiple assessments. The assessments were designed to assess cognitive functioning, behavioral functioning, and issues related to psychopathology. So they took a very comprehensive approach to looking at what's going on with these individuals when we place them in segregation. I'm not going to go through all of the findings. They published a very detailed report with the National Institute of Justice, a couple hundred pages. They published a comprehensive paper in a scientific journal. But what I'm going to hit on here are three of the primary takeaways, the key findings from the study. First off, what they found, that bullet point number one, that segregation placement was not generally associated with the onset of severe psychiatric or psychological disturbance or cognitive impairments for inmates with or without mental illness. In other words, putting inmates in segregation did not typically, in a general sense, again, we're talking about averages here, did not create the onset of severe onset of new illness or disturbances. Okay, and in particular, when compared to inmates in general population, the results, and I quoted this right out of the paper, the results did not support the hypothesis that inmates with or without mental illness experienced significant psychological decline in ADSEG. That is, they did not get significantly and substantially worse when placed in segregation. These authors, O'Keefe and colleagues, explain that the placement in segregation or any special needs prison, it does present a state of crisis. It does result in the onset of disturbance, but that, like most people, inmates are resilient and they quickly adapt and learn to cope with their new confinement conditions or the situation of their new confinement, such that over time, they display no more severe illnesses than those folks in the general population not placed in segregation. All right. Now, this is a well-controlled study. It's very well done, but it's not without its flaws. There certainly were some problems in terms of inmates moving from segregation and into general population and things like that. So there was some attrition issues and things of that nature. But to date, this is the most well-constructed and most sophisticated experimental design we have on the issue of segregation. And what they found, again, that first bullet point, is that segregation in and of itself did not seem to cause the severe deterioration that many have alluded to or attributed to segregation in prior non-empirically designed studies.
There's some questions about potential, if there's any racial factors or if these studies have looked at that explicitly, or gender differences as well.
That's a good question. At this stage, the research has really been looking at the issue of iatrogenic effects of segregation placement broadly, and not looking at individual factors on the basis of the inmate population. There is some movement to start looking at, well, what are the conditions of the segregation placement? But that's different than looking at individual characteristics of the inmates placed in segregation beyond the issue of mental illness. There's been a little bit of research on age and such, but there have been a few studies that looked at race and that sort of things, but not in direct examination like was done in the Colorado study, more through meta-analyses. So we're just starting to tap into looking at who does better, who does not as well. And actually, this is an area of research that Ashley and I are just beginning to look at with another colleague, Ryan Lebrecht out of Florida, to try to tackle some of those issues. But at this point, after the Colorado study, we're still struck with these two competing bodies of research. And those of us in the research field looking at segregation really kind of fall on one of two sides of the fence. It's either still concluding and of the opinion that segregation is harmful and detrimental to inmates' well-being, versus those that would suggest maybe it's not as bad as we thought. And let me be very clear here. If for those in the camp that think maybe segregation isn't as bad as we thought, that's not the same as saying segregation is a good practice. I'm on the record for saying that I don't believe, and I'll show you, I'm jumping to the punchline here, but to make an important point, I'm on record saying that I don't believe segregation causes the harms that have been alluded to by some in the literature. But I'm also on record saying that doesn't suggest that segregation or the use of long-term segregation is a good practice, and doesn't support its use in all cases. I think that's a very important distinction to make. So we'll probably make that point a couple different times. But where we were left at this stage was we had two competing bodies of research, and one way to try to parse out what do we really know from this body of research is to use meta-analysis. For those of you not familiar with meta-analysis, that's a statistical technique where you take the body of research, all of the available research, and you essentially put it into one pot and use that research to make sense of the magnitude of effects that you can get from a particular intervention, whether that be psychotherapy, whether that be medication, or in our case, whether that be segregation. So that was the next step in building the body of research to understand effects of segregation. This was a meta-analysis that Ashley and I and a few colleagues did. It was actually two meta-analyses that we published in one paper. Two independent research teams were conducting independent meta-analyses. We became aware of each other's work, so we put the meta-analyses together into one paper, and that's what we're going to report on here. I'm going to first talk about our specific meta-analyses, where we reviewed actually thousands and thousands. It was almost 20,000 documents, and we whittled those down because we wanted to be inclusive and make sure we didn't miss anything. We whittled those down to those that we thought addressed the issue of segregation, and that's where we ended up with 150 documents. From those 150 documents, we had inclusion criteria to look at, did they produce empirical data regarding the effects of segregation? Was it a controlled study, things of that nature? And so we ended up with then the number of studies that we could include in our research. And for us, that was 14 studies. And from those 14 studies, we were able to cull 65 effect sizes. Our colleagues who published their meta-analyses with us in the same paper reviewed a similar number of documents, around 125 to 150. They whittled that down to 17 research studies. So they had a little bit broader inclusion criteria. And with that, they had a few more effect sizes. All right. So what did we... Ashley, can you forward it? It's not forwarding for me. There we go. Thank you. All right. And what we were interested in looking at was similar to the O'Keefe study, was looking at the broad effects, if you will, from segregation. We wanted to look at behavioral functioning, particularly self-harm, instances of victimization. We also wanted to look at post-release functioning, so criminal recidivism. We looked at their physical health, their cognitive functioning, mental health functioning, mental health functioning to include anxiety, depression, social interaction, things of that nature. We were also looking at antisocial indicators, so their behavioral functioning, as well as, again, the social interaction. All right. Okay, and what did we find? I'll give you about 10 seconds and you'll digest this table. I'm joking. There's a lot of numbers there. I'm violating every rule there is with regard to presenting research in a presentation with this one slide, because there's far too much information and numbers here. So what I want to direct your attention to is this column right here, the ES right here. Hopefully you can see my cursor. Yeah,
Yes.
thanks, Ashley. This is effect size. Effect size is a data point to tell us the magnitude of effect that we can expect to get from a particular intervention. If you have a headache and you take an aspirin, you can expect some effect, some positive gain from taking that medication. And the number, the numerical indicator of that effect is what we would call an effect size. So what we're looking at here across these indicators, these behavioral outcomes, are the magnitude of effect that we can expect when we place somebody in segregation. Okay, so let me make sense of these numbers, because you can see there's a range somewhere between 0.3 to 0.8, although there are some that are lower than 0.3. All right. When looking at these numbers, we typically are going to classify these for simplicity purposes. We're going to classify these into one of three categories: small, medium or moderate, or large. Small effects are going to be somewhere between 0.1 and 0.15. Okay, so this, for example, 0.15. That's going to be what we would consider a small effect. A moderate effect would be somewhere between about 0.2 to about 0.5, 0.2 to 0.45, 0.5. That would be a moderate effect. And then anything above 0.5, oftentimes we're going to consider to be somewhat large effects. So in looking at our data here, you can see we have, from this list of variables, all of these variables over here, we have three outcomes that are in the large range, and the rest are in the moderate, medium, or small range. Okay, this would suggest, or what this tells us is that when you look at the body of research, and a caveat is, again, we're culling the body of research that's empirical in nature. Qualitative case design types of studies that don't have numerical values cannot be included in a meta-analysis. So this is looking strictly at the body of research that used data and quantifiable data to come to their conclusions. When we pull all of that information together, what we find is that, with few exceptions, inmates placed in segregation experience some small to medium negative effects resulting from that segregation placement. Okay, so I believe, and Ashley is of the same opinion, we would submit that if you place an inmate in segregation, you take an inmate from general population, you put them in segregation, you can expect, on average, small to moderate effects, negative effects, on a range of mental health and cognitive functioning. Okay, there will be an iatrogenic effect from that segregation placement. They will feel a little bit worse. Okay. The question, though, is that magnitude of effect. I think there's two questions with that. What do we make of that magnitude of effect, and is that permanent, or does that change once a period of coping or exposure occurs? Okay. Whoops. Okay, and so I took a look at the body of research on the effects of the effects of incarceration as a general matter. Okay, so when you put somebody in prison, you can expect that there's going to be a negative effect, right? And that's what this is. This is a meta-analysis completed by Jim Balta and Paul Gendreau, a couple colleagues in Canada. They completed this meta-analysis in 1990. So admittedly, it's a bit dated, but this isn't a body of research that a lot of people spend time on. So there's At least I haven't been able to find anything more recent. But this was a meta-analysis, and what they found with incarceration as a general matter, as it affects general mental health functioning, so this isn't any one system, just general mental health functioning as a whole, is that they get a moderate effect, 0.44. You take somebody from the streets or from the jail and you put them in prison, they're going to experience distress. And the magnitude of that distress is going to be in the moderate range right here. Well, if you look at our data from our meta-analysis, which is all of these variables, hypersensitivity, cognitive functioning, anger, you can read the rest. And we look at the effects relative to incarceration as a general matter, other than those three particular variables, which includes some depression, and the one that's of particular concern is that self-harm. Okay, that was, if I go back, that was the highest, 0.78. That's a large effect, and that's dealing with harming oneself. That's obviously a concern. But beyond those issues, segregation as a whole produces an effect on par with what you can expect when you take somebody from jail and put them in prison, or you take somebody from the streets and you put them in jail. That increase in correctional confinement creates distress. It appears at all levels, including desegregation, but the magnitude of effect when you place somebody in segregation from the general population is no different the magnitude of effect when you take a person from the streets and put them in jail, or take people from jail and put them in prison. Okay. Again, with a couple exceptions, that being mood and self-harm. And I'm going to come back and talk about those in a moment. Okay. I see the chat moving and I see the Q&A. Are there any questions I need to address, Ashley, or good to keep going?
Yeah, somebody asked why the other effect size, the larger effect sizes weren't included in the chart. I don't know if you had a...
Well, I'm certainly not hiding anything. You can see them. Whoops, why is it not working? I'm trying to go back one, Ashley.
I don't know why you're having a problem over there.
I don't know, it's not working. So the 0.78, the 0.61, I just pulled some of them. I put one of the three that I've circled here, the mood and emotion, in the chart, which is right here, the 0.55. The other two would be about here. And again, so those three, I put the lowest of the three here, knowing that the other two would obviously be a little bit higher. So I did it just, I was trying to fit as much in as I could and trying to capture the holistic perspective. Just like on the lower end, I don't have all of the variables included. So it was just trying to make the chart fit and capture the general message. Okay. So
a few other questions. Sorry, there are a lot of questions, so I apologize if we don't get to everything that people have been asking. But another question was, did this study control for mental health diagnoses? And somebody else pointing out the fact that the p-values on the previous slide, most of which were not significant. So I don't know if you want to address either of that.
Yeah, so most of the differences here are not statistically significant, but you know, when you're looking at the effect of an intervention, so the effect size here would be comparing those folks in segregation to the control conditions in those studies where there were control conditions. And what we were more interested in, not so much is there a significant difference between those folks in segregation, those folks in general population. O'Keefe and other studies are looking at, have addressed that. What we wanted to know is when there are differences, what's the magnitude of those differences? And that's why I'm focusing on the effect sizes. The second question, what was the second question, Ashley?
Mental health diagnoses.
Oh, no, we did not control for mental health diagnoses in this particular study. We weren't looking at differences between those inmates as it pertains to here with mental illness versus those without. But O'Keefe did that, and those are areas of interest that we've looked at in other capacities or are starting to. Okay, so at this point, anything else I need to address, Ashley, before I move on?
I don't think so.
Okay, so at this point, again, we have two competing bodies of research, but we have a pretty holistic research synthesis here that would suggest with fairly conclusive data that yes, in fact, putting somebody in segregation does cause distress, does cause some harm, but that the magnitude of that harm is no worse than what inmates are experiencing in other situations or transitions within the correctional situation. But we weren't done. Okay, we wanted to look at what about more long-term segregation. So the O'Keefe study was up to a year. Everything we looked at in that meta-analysis was up to 1 year. So we had opportunity. This is actually a student that Ashley and I both worked with that had data from a state Department of Corrections with inmates in segregation for longer than 1 year. And so we had an opportunity to look at pre and post tests. So before they came into segregation and then after a period of confinement. Okay. Again, looking up to 4 years. Okay. And we pulled a general population sample that matched our inmates in segregation. So we had a comparable sample from the general population, comparable in terms of age, risk, those types of things. All right. And our primary question here was, does psychological functioning, does illness, do the inmates in general by way of mental health deteriorate over time spent in segregation? Meaning, as they spend more time in segregation, are they getting worse? All right. So one of our primary measures here was the MCMI. Just to give you a very quick sample, the MCMI, that's the Milan Clinical Multi-Axis Inventory. It's a sample of severe psychiatric symptoms and personality disorders. All right. It's designed to coincide with the DSM. So if you're going to diagnose somebody with an anxiety disorder, they would probably score high on the anxiety scale. If you're going to diagnose somebody with depression, they're going to score high on the dysthymia or major depression scale. So it's designed specifically to mirror what's happening in terms of the symptomatology associated with severe mental illness. And what we were particularly interested in this study was change across these clinical syndromes and the severe clinical syndromes. Severe clinical syndromes being thought disorder, so hallucinating, having delusions, that sort of thing, major depression, everything you would associate with that, and delusional disorder. Okay, we were also interested in these other severe, but not quite as severe as these three types of disorders and symptoms. All right. And what we found across all of these variables, with the exception of one, was no difference between those inmates in segregation and those inmates in general population. That being, when you put inmates in segregation, they did not deteriorate in terms of their functioning across these scales, with the exception of one scale, that being the major depression. And here you can see the pre and post scores on the major depression scale. A couple notes here. First, if you look at the scale, I don't have the categories indicated over there, but neither, even the highest score here, the 36.54, that doesn't reach the clinical threshold of the MCMI for major depression. So if I go back, the clinical threshold would be up here, and you can see a score of 45 would be down around in here, okay? And this is the clinical threshold that you would be looking at for clinical diagnostic purposes, okay? So even though there's a difference here, it's not a difference in the clinical range as indicated by this measure. But nevertheless, it is true that we found that inmates placed in segregation for longer periods of time did experience more of a depressed mood state relative to their inmates in general population, okay, with a fairly large effect size, 0.83. If you think back to the meta-analyses that I showed earlier, that's not too terribly far off from what we found here, a little bit higher, but in the same range, that you're going to get large effects in terms of mood when looking at issues regarding depression of those folks in segregation. all right? All of the other symptoms, in particular those with very severe cognitive types of disorders, we found no differences. Okay, so this again supports the idea that even with longer periods of segregation placement, we're going to experience some negative impact here. But again, it's in the range of what we would expect with incarceration as a general matter.
And just to add to that, so regarding the second question that we were interested in, there was no difference. I'm going to just go back for a second. There wasn't any difference over time either. So when controlling for time and placement, there wasn't any effect of that. And so the overall conclusion was that even though the general population seemed to sort of improve a little bit, probably because of the ability to adjust to the prison population, the folks in ad-seg, even though they overall did not get worse, they didn't really improve either. And so the conclusion here is that, or at least the underlying message that we got from this study was that ad-seg was kind of preventing, kind of stymieing any sort of growth or opportunities to improve or make changes. And so it kind of puts a lot of that programming on hold for people to be able to adjust or engage in more intensive interventions that may be the reason why those in the general population showed some decline in their psychological distress over time.
Okay. So there are two follow-up studies that I want to highlight, and then we'll wrap up this segment on the research findings. One of which is one of the more recent studies published on the issue of segregation, and then the second one, you get kind of a bird's eye peek, if you will, at some data that isn't yet published, but hopefully will be soon. So the first one is the Walter study published in 2020 in Criminal Justice and Behavior. This was a follow-up study to the O'Keefe, Colorado study. In other words, it's secondary data analysis. He used their data and reanalyzed it to look at the effects of segregation. And he was testing two specific assumptions that are associated with the SHU syndrome. That's what we're looking at here. That psychological deterioration will prevent inmates will be as prevalent in inmates without mental health needs as it is in inmates with mental health needs. That is that all inmates placed in segregation will suffer deterioration regardless of prior mental health functioning. That is that as a practical matter, segregation causes universal harm. Okay, so he was testing that theory or that assumption. And then the second being that psychological deterioration will be significantly more prevalent in those folks with serious mental health needs than without. And so again, he analyzed the O'Keefe data, those 247 data points, or the data from those 247 individuals from segregation, general population, and a psychiatric mental health facility. And I'm just going to cut to the conclusion here. He concluded that psychological deterioration has less to do with confinement in ad-seg because there wasn't universal harm, and inmates with mental illness did not deteriorate more severely or rapidly than inmates without mental illness. So that the deterioration that does occur, which we've consistently found, has less to do with confinement and segregation than it does with the pre-existing mental health needs and conditions of confinement. Okay, so we really have to start looking at the contextual factors when considering impacts from segregation. And then a study that I'm excited about, but we're waiting to publish because we need approval from the correctional system from whom we gathered this data, which is CSC. You can see it there in the front line. CSC is Correctional Services of Canada, which is my colleague Jeremy Mills' employer. We collected this data with their approval, but they have the manuscript and we're waiting for final approval to be able to publish the paper. And they've had that paper for well over a year now. So I don't know when we'll ever be able to put this out there at large. But what we found with 204 federal inmates in CSC, looking at their mental health functioning over time, again, similar to the Chaddock study, we assessed, these individuals were assessed upon entry, and then we assessed them, well, Jeremy specifically, assessed them during the course of their placement in segregation, okay? And a couple key findings: the inmates who experienced segregation as a class or as a group did not experience a lasting deterioration in mental health functioning, and that few inmates deteriorated in terms of their mental health functioning over time, such that the longer they were in segregation, the better adjusted that they were. So it's the case where there was some initial negative impact, just like we find in other studies, but as inmates spent more time in segregation and became accustomed or acclimated to the environment, that distress or disturbance leveled out. And what we concluded in this paper, which is similar to what I've concluded in the previous work I've done, particularly the meta-analysis, that when you place somebody in segregation, on average, you can expect some deterioration in terms of mental health functioning, on average. But when you look at individuals, some individuals are going to experience minimal harms, some are going to experience more substantial harm, and some are going to experience no effect at all. In fact, they will actually improve in terms of their functioning. And whenever I make that statement, particularly to laypersons who don't understand conditions of confinement and how segregation might work, they almost gasp with, how could you place somebody in segregation and they not be harmed? For some inmates, segregation provides a respite, a break, if you will, from the stressors of general population. So for example, if you have an inmate with gang problems or gambling debts, and you take them out of segregation and put them in, you take them out of the general population and put them in segregation, they're going to experience a decrease in anxiety, a decrease in stress. They're going to feel an increase in safety. Okay, so there can be a positive effect. But in general, when you place somebody in segregation, you can expect some negative effects from segregation. And where we ultimately conclude is that although segregation does not cause the harms and the traumatic outcomes that some have alluded to in the literature, it nevertheless is a practice that we need to look at addressing in terms of doing it better. It's not good correctional practice to put somebody in segregation. I've worked or had the opportunity to interview inmates that were in segregation for 15, 20, 30 years. There's no way around it other than to say that's pretty poor correctional practice. We certainly can do better. We know we have methods that will work much more effectively than using segregation. And so we can do better. So even though Ashley and I are highlighting here that the research would suggest that the harms caused by segregation aren't as great and as exaggerated as some would conclude or have us believe, our findings don't support overuse of segregation as a correctional practice. I have some other thoughts in my head, but for sake of time, I'll stop there. I know Ashley's ready to move on with other stuff, so I'll stop and take just a moment to address any of the questions. Ashley, are there questions I need to respond to?
Yeah, I'm going to try to clump some of them together, but a few people mentioned differences with antisocial personality and how that might affect responses to segregation. I don't know if you have any thoughts about that. One person suggested that antisocial personality might somehow reduce emotional reactivity to segregation. Do you have any thoughts?
Not so much in terms of that reactivity question. That's an interesting thought. I'll go back and read the chat in full when Ashley starts, because I want to see your thoughts on that one. You know, essentially, I think what we find, particularly with the behavioral outcomes, you know, that self-harm, there are two outcomes that I think are clear problems with the use of segregation, and that is self-harm and recidivism. I think we absolutely need to do better by way of making sure we don't release people from segregation to the streets. That's almost a surefire way to ensure failure. You release somebody from segregation straight to the streets, they're going to be overwhelmed. They need that period of transition to be around other people before they're thrust out into the streets. We also have a problem in terms of self-harm. People are more likely to harm themselves when in segregation. The problem with that is the people we put in segregation are what we would typically deem the worst of the worst. And they're the people that are acting out the most, both towards others, but also towards themselves. Okay. So the issue of the personality disorders, antisocial and borderline in particular, what we're doing is we're putting people in segregation who are prone to acting out against others and against themselves. And it's no surprise to find that they continue those behaviors, even when placed in segregation. All right. I don't believe necessarily that having antisocial personality disorder protects one from psychological harms associated with segregation placement. You can be pretty antisocial and still feel bad about your placement. So I don't think antisocial personality disorder would be a protective factor, but I do think those personality disorders can explain why, in part, why we see some of the more negative outcomes on those behavioral indicators, because again, the idea with that segregation is you're taking the worst of the worst. Well, they're going to be expected to behave like the worst of the worst, even during and after their segregation placement. So those are some of the individual factors that we need to parse out and try to make sense of as we move forward.
And a couple of people kind of commented when you were, talking about segregation being sort of a pause point for a lot of people. Somebody referred to it as seg vacation, to catch up on sleep or have privacy, cope with recent stressors. So
that's spot on. I'm in total agreement with, I don't know who said that, but whoever put that in the chat, I'm in agreement. And those would be some of the individuals that don't suffer the harms associated with segregation. Again, my general opinion is you put people in segregation, some are going to suffer no harm, some are going to suffer harm, and some are going to feel a little bit better, just as we concluded in the very last 2 lines there of this slide.
Yeah, and somebody else commented about individuals or patients with psychotic or schizophrenia spectrum disorders having lower ability to adjust. And I think most people would agree that, those with really serious mental illnesses, if and whenever possible, should be not held in segregation, or at least not for long-term periods of time.
Yeah, segregation for people with severe psychosis, other severe depression, bipolar disorder. If you use segregation with those individuals, it should be just a very temporary placement while you're figuring out alternative placements. If you're going to send them to a prison medical unit, for example, and it's going to take a day or 2 for the transfer, you might use segregation to keep them safe from others or themselves during that day or 2 while you're waiting transportation. But segregation is not a behavioral management strategy that should be used for managing severe mental illnesses.
As somebody also commented about jail versus prison, and Bob and I actually just wrote a chapter on this that is being submitted to the publishers for publication on restrictive housing in jail specifically. And unfortunately, the research is far more limited in terms of jail settings. And we know that jail settings represent a higher rate of turnover, different staffing limitations, just a different dynamic and demographic of inmate population. And so it's certainly important to branch out and to look at jail settings as well. But we don't have as much research on jail settings because of some of the rates of turnover and difficulties doing more longitudinal research in those settings. Would you agree?
Yes. Yep. You covered it.
So for anyone who's interested in research or doing jail stuff, definitely an important area to expand upon. Okay. Let me see. Okay, so based on what Bob was talking about in terms of the research and summarizing what's going on empirically, what can we conclude so far? It seems like we can kind of draw 2 general conclusions here. One, that segregation is not as bad as we thought, but it's likely associated with some increases in mental health dysfunction and dependent on maybe other circumstances like the environment, inmate staff relations, things like that. Or perhaps you could argue that it is still bad, but we haven't captured the severity of the problem yet. And I think, to echo what Bob was saying earlier, and we don't have the body of research that we have so far would not suggest that overall segregation, really kind of represents a torturous correctional practice with exceptions. Certainly, we talked about the Khalif Browder case earlier, and other there's other uses of that practice that have been that have come to the media attention, and are certainly things that are inappropriate uses of this practice. And we certainly do need more research. Again, we just talked about research with jails, more research in forensic hospitals. Somebody mentioned in the chat earlier about some of this work being applied to forensic hospitals, and we certainly do have some gaps in the literature. We need larger sample sizes. Certainly need other measures of functioning, so not just MCMI scores, but also behavioral, cognitive, physical outcomes, disciplinary. Are people? What does it look like in terms of the records? More post-release outcomes, examining individuals with pre-existing mental health issues, which some of the newer research is looking at that. And again, taking into account the nature of the segregation environment, how are people operationalizing segregation? I saw some questions about whether reasons for the segregation placement were looked at, or what kind of privileges people have access to. And unfortunately, some of the research out there doesn't report on the actual conditions of the segregation environment, and certainly a lot of the impacts resulting from that likely are differentiated by what the environment actually looks like. So certainly there's more research to be done, but I would reiterate the point that it's a lot more nuanced than we might have thought originally. If you think back to that polling question with a lot of you indicating that segregation causes significant effects, I wonder if some of you would have rated that a little bit differently after this review of the literature. So what do we do now? I mean, so maybe it's not as bad as we thought it was. And again, there's more nuanced outcomes depending on the environment, depending on the purpose or reason, or, again, not allowing people with serious psychotic or other serious mental illnesses to spend long periods of time in these placements. And we know we shouldn't be doing those sorts of things. But knowing that it isn't as bad in many cases as we once believed, what do we do? Well, as Bob was talking about earlier, this certainly isn't the recommended correctional practice. And so reforms are still greatly needed. And there's been a lot of discussion, especially recently, talking about some of these reforms and what can institutions do in particular, or departments of corrections more broadly, to reform some of the ways that they're using restricted housing. So I'm going to go through a couple of the proposed reforms, or reforms that are coming to the forefront as of recently. So one is to reduce or eliminate, of course, the practice for juveniles, those with disabilities, women who are pregnant, again, people with serious mental illnesses, sort of those vulnerable populations, to reduce or eliminate the practice for those groups. Reducing the use of indeterminate placements or placing restrictions on stays. So as Bob mentioned, there's some individuals who are spending decades in these more isolated or more restrictive environments. And so eliminating the use of those placements, and actually maybe even mandating restrictions on how long people can stay in those settings in one place or at one time. It's also been proposed to create some specialized units for people with more serious behavioral problems so that they can be contained, and we can implement actual interventions to address some of those more problematic and violent behaviors. Mandating additional out-of-cell time and specific rehabilitative programming, so similar to the creation of treatment units, other kinds of programming directly targeting some of these risk factors that make people more prone to being placed in these settings. Adding due process protections and access to counsel. So when people are feeling, like the conditions of their confinement are unconstitutional or inhumane, that they have a process in which they can file those grievances, and that they have access to counsel to help them navigate that system. providing specialized training to staff working on segregated units. I'm aware of some programs and some efforts being done, and maybe some of you have had experience with this, of trainings, not just putting any staff on segregation units, but training staff particularly to identify symptoms of mental health, decompensation, targeting. Bob and I are now working on a program to help correctional staff address errors in cognition, so criminal thinking styles and things like that. So training staff specifically to work with the types of inmates who, again, tend to be placed on these units. And prohibiting the denial of basic services or needs like food with women. It might be things like sanitary products, personal hygiene, tampons, things like that. So not allowing for institutions to deprive people of kind of these basic needs and basic services. So if any of that sounds familiar, some of you may work in the New York system. A lot of those reforms actually are coming directly from this HALT Act. I can't remember off the top of my head what HALT means, but this is an act that was actually recently signed just about a month ago by Governor Cuomo in the state of New York to implement a lot of those reforms that we were just talking about on the previous slide. And so there are some statewide efforts to try to address and try to enact and implement some of those reform efforts. Another area of research and interest is, can we maybe assess people at the forefront of when they either come into the institution or, after a period of adjustment following booking? Can we do something to assess risk and maybe use that to either triage individuals or get them into some specialized programming to sort of prevent their placement in segregation restrictive housing units? And so there's been two sets of researchers in particular who have looked at risk assessment tools to try to identify some of these factors. Bob mentioned earlier Ryan Lebrecht. Him and his team recently created the Inmate Risk Assessment for Segregation Placement, the RASP tool. And so this was, again, a tool that was developed to try to address some of these or kind of identify some of these risk factors for the purposes of triage. And so some of these, again, were factors that are available when people first come into an institution. So they're variables that are known, or at least can be data can easily be gathered on these things when people first come in. So it doesn't necessarily take into account factors that may become available once the person is in the institution. So it doesn't take into account, for example, the number of disciplinary infractions that they've gotten, or other things that may later on make somebody more risky for those placement settings. So of the factors that they looked at age at intake, their sentence length, sentence type, which was dichotomized into violent or nonviolent, whether the individual had known gang affiliations, serious mental illness, and they also looked at their initial classification rating. So for example, if they were minimum, medium, max, close custody, those sorts of things. And so this was in a US sample. And what they found in their validation study in 2019 was that the tool was predictive of placements in segregation, and it was predictive regardless of race, which again was dichotomized to Black inmates and white inmates. And so in this again, this initial validation study did not find any predictive differences in terms of race or gender, so across men and women. And then almost simultaneously, Helmuth and colleagues also developed a similar type of risk tool, the risk of administrative segregation tool, the RAST, in the same year. And the primary difference here is that this was in a Canadian sample versus a US sample. And they looked at some similar risk factors. So again, age at admissions, number of prior convictions, prior segregation admissions, Again, sentence length, which we also saw with the RASP tool, criminal versatility, and this was in regard to offense variety. And so there were different types of offenses like assault, robbery, drug offenses. And so the more diverse your offense history was, that kind of counted against you. And then prior violent convictions. And so similarly to the RASP from Lebrecht and colleagues, they found that the tool was predictive of placements for both women and Indigenous offenders. And so both of these tools are primarily focused on static variables, although the Helmus tool does come with a second instrument that looks at some of the dynamic factors such as criminal friends, impulsivity, whether they're employed or have been employed and things like that. So, but these are primarily static tools that, again, are intended for use at the beginning of somebody's, or more towards the beginning of somebody's incarceration to try to identify who might be at most risk for later segregation placements for triage purposes. So what is the challenge with all these? There's a lot of really great reforms, a lot of really great efforts out there to try to minimize the impact, minimize the length of stay, minimize the type of individuals who are placed in settings. So what might be a challenge with some of these things? I don't know if some of you can kind of put in the chat box or in the question and answer box. What are some challenges that you perceive with the implementation of these reforms?
Ashley, you have one question in the chat whenever you get a moment.
Okay, I don't have that box pulled up.
Not the chat, sorry, the Q&A. I'll read it to you. Any thoughts on persons' right to refuse supportive interventions, safety plans, behavioral plans, et cetera, in placement decisions?
Bob, are you aware of laws pertaining to that? I think my understanding is that states have their own laws about what kind of interventions can be forced upon individuals.
Yeah, if it's a supportive intervention, inmates have a right to refuse any sort of intervention that's not a correctional security intervention. You know, they don't have the right to refuse to go into segregation, but once in segregation, they have the right to refuse to participate in behavioral management plans, safety plans, things of that nature.
Yeah. So as far as the challenges, I'm seeing a lot of people type things in like staff shortages, buy-in from staff, inconsistent implementation or adherence to the reforms from correctional staff and higher ups. One huge challenge is, again, buy-in from custody staff, criminalization of mental illness. So a lot of those reforms are really, really great, but there are certainly some barriers to the implementation of that. And one of the main barriers that I see is that these reforms, as good as they might seem, cost money, money that a lot of DOCs do not have. A lot of, I'm sure a lot of you have experience with this, but, you know, having been in Mississippi and now Tennessee, especially these southern states, are sometimes working with budgets that are very small or even budget deficits that they're trying to overcome. And so even increasing out of cell time can have a high cost for jails or prisons, especially rural jails, small hospitals that just don't have the money to hire more security staff, because when you increase out of cell time, you also have to have a staff member to supervise and monitor what that individual is doing. And while those triage assessments are low cost and they might take up few staffing resources, what happens when facilities don't have anything for inmates to triage to other than a segregation unit? And so there's certainly these real world barriers that sometimes come into play depending on where the facility is located, how many resources they have, how many staff members they have, and you know what funds they're able to use to implement these changes. Somebody also put in that some behavior is so violent, including individuals with known mental illnesses, that it's difficult to find other management strategies for them, especially again when there are fewer options within a given facility. So what else can be done? And this is going to kind of lead us into the intervention discussions. And so maybe I'll go through another slide or two. And I don't know, Bob, if you want to take maybe a 5-minute break.
Yeah.
I think that would be good. Okay. I know none of you can see or hear us, or we can't see or hear you. So you've probably all been taking breaks as you needed them, but we'll take a couple minute break after the next few slides. So like I said, I think this is kind of where we're going to transition into some of the treatment stuff. And what can you do when you don't have the capacity to implement some of these larger reform efforts? And so one of our focus has been, how can we use someone's time wisely? So when they're contained, what rather than just letting them sit there, if you think back to the Chaddock study where we showed that, the people in segregation, even though they didn't get significantly worse, they didn't really adjust in the same way that the general population did or show some improvements in their functioning. And so they just kind of stayed stagnant a little bit. And so we've been focusing on, how do we use this idle time wisely? And so we started to think about how we can focus on initial programming once people are in that, setting, right? Because we know when people get bored in segregation, these are the kinds of things that they get into, right? They make, send kites or make weapons or flood their toilets and all kinds of things that are not useful. So this kind of makes sense, right? So why are we not doing this already, or why are we not hearing a lot about segregation focused programming? And again, a lot of these are things that people mentioned before. We've got security limitations, confidentiality limitations. So it's often difficult to bring someone out of their cell, but the alternative is to just stand in front of their cell and yell through the door. When I was collecting data for my dissertation several years back on segregation, they used to call it seg ears because it's very hard to hear in there. But then once you sort of got into the environment and adjusted a little bit, you could hear more. But standing in front of a cell and yelling through the meal slot or whatever is kind of a confidentiality issue. And there's other folks have already mentioned staffing, resources, or staffing and resource limitations, that it's just hard for staff to have the time to go into those facilities, or the time it takes and the staffing availability that's needed to pull people out of those cells can be difficult. And then until relatively recently, we've lacked specialized programming for individuals in segregation. And so that's kind of where we're going to lead into. And I have one polling question here before we take a few minutes break. I'm curious what is available at your institution. So if you're working in a correctional facility or even in a forensic hospital, I'm curious if your facility offers any specialized mental health treatment for clients placed in or even prone to restrictive and segregated housing. So I'm going to launch this poll and see what folks say.
And actually, there's a question there by Catherine in the chat, not in the Q&A.
Okay.
What about mediation, mindfulness training, relaxation, breathing, music, yoga through a microphone? You might want to touch on that. That falls right in your alley to some degree.
Yeah, actually, the Stepping Up, Stepping Out program that we're going to go into some detail about, we do integrate meditation and mindfulness exercises into and breathing exercises into that program as well. I've not seen yoga being done through a microphone throughout cells, so I would be kind of curious what that looks like, or how that goes over, or how that's implemented, or what the positive outcomes are of that. So I've not seen that in the research, so I don't know what that looks like exactly. But I agree that meditation, mindfulness, relaxation, those are helpful coping strategies that are integrated into the programming that we're going to talk about. So in looking at the poll, it looks like 73% said that, that you are using some kind of specialized mental health treatment for people in these units, which is good. We actually, I just looked at some of our results yesterday, but we attempted to do a national survey to see what kinds of programming people were doing in segregation. And unfortunately, we had a lot of trouble getting people to respond to us and tell us what exactly they were doing. But we found that a very small percent of people who responded to our survey said that they did not have much programming for inmates in these housing units, and even less programming that was specifically developed for their needs. So I'm glad to see that there is some programming going on. Maybe I'll send you my survey and you can complete it and let us know what's really going on. But we had some trouble getting some questions answered nationally. But thank you for that poll. And I guess with that, we'll maybe take I can share the results with everybody. Those were the results of this.
This time we could see it.
Okay. I missed that little feature at the bottom that I could share with you. Okay. So do you want to take a little bit of a break here, maybe until, we're on Central Time Zone, so 11:45.
Yeah, we'll resume at 11:45.
Okay. Sounds good. Are you moving your mouse over there? What are you doing?
I don't know. I'm trying to get. I'm all jacked up.
Stop touching stuff.
I can't even get my video. Nothing's popping up for my video and mute button.
Well, I can hear you.
Yeah, I got that off. Now I'm trying to figure out start my video. There it came up.
Okay, I was like, what? I just see all this stuff moving around. Like, what was he touching over here?
Yeah, that was me.
All right.
Did you give me a time? Did you see my text? Give me a time frame on the one.
Like no more than 10 minutes. Can you
Oh,
do that?
All right, I'll do that. I'll make it work.
It's all right. We'll get it all done.
It'll be good.
Okay, I don't know if people are still trickling back or not, but we'll get back going here. Again, thank you all for your engagement and questions and comments. And I apologize again if we don't get to all of them, but they're really great points of feedback and engagement. And we also still have over 200 people still tuned in. So that's really great. I'm glad to have so much participation and attendance today. Okay, so before we left for just what seemed like a very brief break, we were talking about some specialized programming that was available at institutions, and a lot of you said that you were working in an institution or a facility where there was some specialized programming, so that's good. And so let's talk about a few things that are most often available for inmates who are in segregated or restrictive housing units. And so a lot of these may be things that are available in your own institution. For one, there's brief self-front check-ins or rounds. So just kind of going around and doing some very brief check-ins with individuals, making sure they're not significantly decompensating or having suicidal ideation, things like that. Medication management is also pretty common for these individuals, seeing psychiatric staff to monitor medications. Every now and then in-person meetings that can take place on the unit. Again, it's often difficult to extract people or remove them from these units in a safe and secure way, but sometimes this is something that's able to happen. Art therapy is common. Self-help materials. I think I saw somebody in the chat say that somebody was using bibliotherapy or giving lots of reading materials. And also group therapy also happens in prison settings in general a lot. One, because it's more efficient. You can treat a bunch of people at the same time, and you don't need as many staff available. But oftentimes, and some of you may have seen these, group therapy can look a little bit like this. These are called therapeutic treatment modules. This is a picture from San Quentin prison where they basically pull these individuals out of their cells and then put them into these telephone booth sized compartments or whatever you want to call them. And this is how they do group therapy. So, some of you may have seen these. They're probably not the most humane or therapeutic way to actually go about delivering services. This guy over here on the left probably is not able to hear the guy on the right very much. And so there's definitely some barriers to doing this as well. So before we get into, again, the Stepping Up, Stepping Out program, Bob is going to talk to you just very briefly about best practices in correctional treatment as kind of a foundation to the Stepping Up, Stepping Out program. And again, a lot of this is probably familiar to many of you who are listening, especially those who follow the risk needs responsivity model. So I'm going to turn it over to Bob to give you a crash course in correctional treatment, just so everybody's on the same page.
If you didn't catch that, she twice emphasized the brevity of this segment. She said brief and crash course. That's her cue to me to be quick and efficient. She gave me 10 minutes. So I'm going to come in at 9 minutes and 55 seconds, just so Ashley will be pleased. Okay, so For those of you that don't know, R&R, I assume at this point most people are at least familiar with the concepts of R&R, but I'm just going to give the umbrella perspective here. R&R is a model for intervening in corrections. It's not a treatment program. It's not a specific intervention. Again, it's a roadmap, if you will, for how to produce, at least to date, the most effective outcomes that we've been able to identify. And so it centers around three principles: a risk principle, need principle, and principle of responsivity. The risk principle is pretty straightforward. That means that we should assess individuals for their risk and identify their risk, and then provide services in line with their level of risk, with the idea being that we're going to provide the most intensive services for those folks at moderate to higher risk for recidivism. That little is gained by putting intensive services towards folks low in risk for criminal recidivism. They're unlikely to recidivate, so we don't need to spend a lot of our resources on those individuals. The need principle indicates that we should provide services that target the needs, those criminogenic risk factors, if you will, that put people at risk, at moderate to high risk for reoffending. And then in terms of responsivity, that we should provide services in a manner that's consistent with the learning style and with the needs of the individuals that we serve, that we should tailor our services to match the needs to match the needs of the individuals we serve. To give you one very quick example of that, stepping up, stepping out is an intervention based on common correctional principles that we know that work and designed in a program that's conducive to the needs of inmates in segregation. So it doesn't follow typical psychotherapeutic strategies, because you can't necessarily administer those in a segregation environment, at least not well. So it's tailored, it's responsive, if you will, to the needs of individuals in segregation. So that's R&R, risk, need, and responsivity. So
did you need me to go on? Sorry, I thought you were clicking over there.
Stuck. Yeah. Help.
Which slide do you want me to be on?
The next one.
Okay.
The Central 8. There we go. It's just like grad school all over again. Ashley was here as a graduate student, and I would get stuck, and I would holler. I'd send her an email, and she'd come down and get me on track. So we're just continuing the dream here. All right, the Central 8. This goes to issues that are going to be primary focus when assessing risk, but also give us good indicators for the needs that we need to target in treatment. Once you know the Central 8, if you were to develop an intervention from scratch, you would have a roadmap, an idea of the targets of that intervention based on what we know that works. So we have the Central 8 here. The big four are the four that produce the greatest, account for the greatest variance, if you will, in criminal behavior. We have criminal history. We all recognize that when we learn that in our introductory to psychology courses. The best predictor of future behavior is past behavior. Then we have antisocial personality disorder, basically like you would think of out of the DSM. So it's getting at antisocial psychopathology. And then we get into more dynamic factors. Although I will say antisocial personality is a dynamic factor, it's one that is not easily changed. It's pretty hard to change personality in a global sense. But these next six, in particular the remaining two of the big four, account for a significant portion of the variance and are dynamic and relatively straightforward by way of change. Not easy to change, but we have good strategies for changing these things. The first one being criminal cognitions, or you might sometimes hear it as criminal thinking. That is, people in the justice system think differently than those of us not in the criminal justice system. A colleague and friend of mine is in the audience, Steve Norton. If Steve and I don't know each other and we're walking down the sidewalk and we bump shoulders, and neither one of us is a justice involved or criminally minded individual, what are we going to do? We're going to exchange pleasantries. We're going to say sorry, move on our way, no harm, no foul. However, if one of us is criminal oriented, if we think like a criminal, when we bump shoulders, that innocuous interpersonal interaction suddenly takes on a different tone, because one of us would be thinking, hey, that might have been intentional, it's a power play, and suddenly the whole interaction is different. People in the justice system think differently than people not in the justice system, all right? We also know the more antisocial associates and the more time spent with antisocial associates is a significant predictor of future criminal behavior, right? For those of you of us with children, we recognize this, right? We know that around age 11, 12, 13, somewhere in that age range, our children tend to behave in ways that are less influenced by what we want and by what we state as parents with our expectations than the expectations and wants of their friends, right? Associates matter. The other four are pretty straightforward: family, marital functioning, school, work performance, leisure, recreation time, and substance abuse. We know when you look at these 8 central risk factors that these account for the greatest variance in terms of predicting future criminal behavior. And what's not there? All of us in this webinar today are mental health professionals, and what's the thing that's most obviously not there? Probably you're thinking mental illness and trauma. And that's because they're not the most significant predictors of mental illness. There was a comment in the chat earlier about criminalizing mental illness, and I've done a fair bit of research in that area, as have a number of other colleagues, Jen Scheme in particular out at UC Berkeley. And what we recognize is that although mental illness is related to criminal behavior, it's a minor risk factor because it's not one of the variables that's driving the bus when it comes to crime once you account for these central 8 risk factors. These are the things that prominently contribute to individuals' engagement in crime. Okay, I'm going to skip over this just because of time. Other than
this slide is just depicting the fact that, you know, even though the mental illness is not part of the central 8, we still, and many of you have talked about this, have a higher proportion of people who have mental health issues in correctional settings. So this is comparing community samples to jails and prisons, showing that there's just a higher prevalence of that. And so how can we can't ignore the mental health side in terms of treatment interventions either.
Yeah, and we'll conclude this section with that. And I think this statistic by Torrey is particularly enlightening in that people with serious mental illness are 3 times more likely in this day and age to be justice involved than they are to be placed in a mental health facility. They're more likely to be in jail or prison than they are in a psychiatric hospital. But what we know is that people with serious mental illness that end up justice involved actually share those criminal risk factors, that central 8, with individuals that are not mentally ill. When you look at populations of persons with mental illness and that are justice involved and compare those to inmates that are not mentally ill across all of those central risk factors, which my students and I have done a series of studies on, you tend to find the risk factors being about equivalent, such that we can conclude that it's not mental illness that's resulting in people being ending up in our criminal justice system. It's these criminal risk factors. But as Ashley just said, we actually need to treat both the mental illness and what we call in our treatments the criminalness, because both are prevalent, both are relevant. We have a public health issue with that mental illness, but we also have a public safety issue because they're not locked up just because they're mentally ill. They're locked up because they have serious criminal risk indicators and they happen to be mentally ill as well. So our treatments need to account for this. But historically, what we've done is we put somebody in jail, we put somebody in prison, or we put somebody in a diversion program, and we provide mental health services to reduce their symptomatology with the expectation that there's then going to be a reduction in recidivism. But what we find is this doesn't work. And the reason it doesn't work is because this model does not target the issues that put them at risk for CJ involvement. And what we really need is another box down here next to the symptom reduction that says treat criminal risk. And we have that holistic intervention dealing with the co-occurring issue of mental illness and criminalness. And that's when we're going to get at reducing recidivism. Okay. So I've alluded to that. I summarized all of that research in about 30 seconds. So I'm going to come in even under my 9 minutes and 55 seconds. But this is what we need to be doing. Okay. And we identified this, we called it the bioadaptive model. When working with justice involved persons with mental illness, you need to be doing 2 things. You need to be treating their health issues, the mental health functioning, but we also have to be treating their criminal risk. The data is clear. only about 10% of people with mental illness in the justice system are there as a direct result of the mental illness. That's based on research from Jennifer Scheme and her team. They've done some fantastic work. But when you look at the other 90%, they're generally involved in the justice system because they present with antisocial features, antisocial behaviors, and criminal risks similar to other inmates, other justice involved individuals who are not mentally ill. So our treatment has to be holistic and deal with both the mental illness and the criminal illness. And you're going to see that in stepping out as we take this model and adapt it to our work with inmates in segregation.
There's a question about, so antisocial personality is considered in the central aid, and the question is about whether we also consider psychopathy or if there's no utility in doing that. And
yeah,
I would.
Okay. Good question. I'll answer that one fairly quickly. Psychopathy is just an extreme form of antisocial personality disorder. If you think of antisocial personality disorder on a Likert type scale, psychopathy is going to be the higher quartile, right? The highest 75% and above. And so it's really just an extreme measure of that particular variable. So psychopathy would be subsumed under antisocial personality disorder. You're going to see this in stepping up, stepping out. So I'm not going to spend a lot of time on this other than to say what we did in our treatment programs, one of which is stepping up, stepping out, is we took the best from correctional rehabilitation literature and what we know about what works when working with justice involved individuals. And we took the best from what works when dealing with individuals with serious mental illness. We took the best treatment approaches from psychiatric rehabilitation. And we simply merged those into a comprehensive, holistic intervention. And stepping up, stepping out was developed with Ashley as lead out of this line of work. And there we go.
Thank you. I didn't time you, but I think you were right on the money there.
Early. I was quick. I was early.
Okay, well, that's good. Okay, so we're hopefully going to spend the next 45 minutes or so talking about this particular program, where it fits within some of the issues or challenges that we talked about earlier in terms of implementing some of those larger level reforms, and how we can use some of that time in their cell more wisely, and get them out of that unit more quickly. And so as Bob said, this program really is on the pillar of best practices in correctional psychology, psychiatric treatment, and also Bob kind of almost slipped out, Changing Lives, Changing Outcomes, which is his program that is also has also taken this bi-adaptive approach. And so stepping up, stepping out is based a lot on some of the principles that are in that particular program, but tailored to both the environment of restricted housing and also some of the additional unique needs of those who are placed in this setting. So this program, again, it's a program that we have developed and so know quite a lot about, but it's certainly not the only program out there. Again, I know some of you are in the Bureau of Prisons, and I believe there's a program available in that setting, and some other people developing programs for these particular inmates in these units. So we're going to talk a little bit about how we think this particular program is unique and allows for flexibility depending on what resources are available, what staffing staffing resources people do have within their given institutions. And then we'll kind of talk about how you can, if you're going to use this program or any other program, what you might want to think about in terms of program evaluation. So this is an image of the actual manual, and I'll talk about what's included in that book as well. But essentially, Stepping Up, Stepping Out is a psychoeducational and CBT-based program that, again, is uniquely developed to address both the psychological and the criminogenic factors. So the previous slide where I was talking about what to address in these different categories, we try to address those in different elements or different modules of this particular program. So it's addressing both those psychological and criminogenic factors for individuals in segregated housing, and to try to accommodate some of those institutional barriers that people were talking about earlier. And so in general, we adapted information or strategies across 9 different modules from different types of interventions that, again, are known to work pretty well. Dialectical behavior therapy techniques are built into the program. Again, and I think somebody mentioned this in the chat about the prevalence of people with borderline traits being placed in segregation. There's some research to support that. And so some of those DBT strategies are included. We also include things like acceptance and commitment therapy, illness management and recovery, anger management, assertiveness skills. So a lot of those are built into this program. In terms of the primary goals, the goal is to teach the individual some basic skills to manage some of their problematic thoughts, feelings, and behaviors that they're experiencing, so that they can, one, serve their time in segregation without further incident, and return to the general population where more intensive services can be implemented. So the important note that I want to make is that stepping out is what we've been thinking of as a first step program. So it's not the end all be all, but it's something that's designed to get people started with treatment and to learn, again, these basic skills to help them sustain enough that they can demonstrate that they could go back to the population, where usually there's more resources available. There's group programming, there's educational programming that they can be involved in. So we in no way are suggesting that stepping out is the end of the road for anybody. Who's eligible to participate? Well, of course, incarcerated individuals. Again, the program is designed with prison terminology in mind, but certainly I think the workbook and the information in the workbook could be easily adapted for patients in forensic settings. I have all gender identities here. The program is not as male-centric as many other correctional programs tend to be, but there certainly may be responsivity factors, and we're going to talk about a few as related to women who might be in segregated housing. So even the program is not necessarily for men specifically, and we designed that in mind, knowing that a lot of programs are not particularly useful for women or other gender identities. We also suggest that the program is not just for people who are currently in restrictive housing environments, but it can also be used with people who are, the so-called frequent flyers, people who are constantly going in and out of restricted housing environments. They might also be good candidates for this program. People with more significant mental health or behavioral concerns, since it is that bi-adaptive program where we focus on the mental health and the psychological factors and the behavioral factors. So, for those who are experiencing some mental health distress, would be good candidates for this program. The program also does, in its current form, require individuals to be able to read and write in English, although additional support could be implemented for people with lower reading levels. I know, and I think some people from the Missouri Department of Corrections might be listening in. Those folks are implementing this, and we've actually learned a lot about, accommodations in terms of implementation for this program. And so they've been able to use additional support services for people who are lower reading levels, or have been able to spend more one-on-one time with those folks. The typical completion time for stepping out seems to be about 3 months. So we recommend that people will be able to commit 3 months to it. And it doesn't necessarily need to be 3 months in segregation. If they are released from segregation, can they still commit to completing the program? The workbook, the image of the workbook that I showed you earlier has 2 parts to it. The first part is the clinician guide, and I'm not going to go through all of this, but these are basically the components of the clinician guide. It gives an overview of the program, basic goals, participant rules and expectations, completion policies, as we're going to go into a little bit later, some assessment recommendations. So how can you best assess the person's individual progress, as well as the overall program implementation from a general standpoint. And then the second part of the workbook is the inmate or client workbook. And this includes 45 handouts. There's modules 1 through there's technically 9 modules, but the final module is a relapse prevention booklet. So the meat of the content is in modules 1 through 8. Each one of those modules ends with a module recap to kind of summarize what they've learned. With the exception of module 1 is very short, and so there's not necessarily a need for a recap in that particular module. And then module 9, like I said, is a relapse prevention booklet, and it ends with a letter that the individual is supposed to write to, somebody within the facility who might have some say or authority in whether or not they're going to be released from those units. And I've seen some of those letters, and some of them are quite insightful, and some of them are just like, let me out of here. But so it's interesting to kind of read what people are saying and what they've got from the program, and how they're going to commit to continuing to implement the skills that they learned. When you buy the workbook, you also get access to e-resources. So these are a number of electronic resources that are available to help supplement the program implementation. So again, the assessment measures that we'll go over in a little while. We've purposely selected assessment measures that are non-proprietary, so they wouldn't cost money to obtain or administer, and so these resources have those as appendices, as well as the quizzes and answer keys. So each module, or modules 2 through 8 rather, have pre and post quiz modules to see how they've improved in terms of their knowledge acquisition. The e-resources also include completion certificates, a glossary of terms. So there are points at which the program has a higher reading level because there's terms like segregation or some psychological terminology within the program. And so this is one way we try to mitigate some of the difficulties that people might have in reading or understanding some of those terms. There's also a behavioral log for clinicians to record and keep track of which handouts they're administering, whether people completed assignments that they were supposed to complete, and things like that. And then there's some other supplemental module appendices like extra relaxation exercises, thought logs that can be redistributed to participants. I'm going to go through each of the modules somewhat quickly, but in a bit more detail than what's on this slide in a minute here. But these are the 9 modules of the program. So it starts with a basic introduction, and then you'll see some of the some of the modules reflecting both the mental health side and the criminogenic side. And we've also prioritized suicidal ideation, self-injurious behavior because of, if you think back to the Morgan 2016 article or the meta-analysis, that self-harm piece was the most significant. So we prioritized that in this program. We've also included a module on just coping and how to deal with the more restrictive environment and the difference, so that module, for example, includes some sleep hygiene, other, tolerance related activities. And then you'll see things like seeking supportive allies. This is addressing some of the associates piece. So we'll go into that in some detail in a minute. So like I said, the modules altogether have 45 handouts plus that relapse prevention packet at the end. And this is typically the order in which things go. So there's, as I said, a multiple choice pre-module quiz to just get their baseline understanding of things. The series of handouts, which are supplemented by counselor feedback. I'll get into that in a minute. And then, like I said, most of the modules have a recap at the end to summarize what skills they've learned, and then it concludes with that post-module quiz. Okay. So one of the ways that we think that stepping out is useful, or could be useful for a lot of institutions, is because it is largely inmate self-directed. So again, there's some other programs. Feel free to correct me, anybody who is working in the BOP, but I believe that what I know about the BOP program is that it emphasizes more contact with psychologists and mental health staff, which I think is a good thing. But again, a lot of departments of corrections don't have that ability to increase their psychological staff or their staff of psychologists and aren't really able to increase the level of contact. And so we also think that this module or this program can be flexible. So depending on what if you have the ability to have more staff contact or mental health, if you can do more mental health groups or individual sessions with people, then you can also use this program for that purpose as well. My slide didn't progress. Okay. So as I said, the handouts are largely self-directed. They do require some counselor feedback and guidance to ensure the mastery of concepts. So it's not purely a self-help program. I want to make sure that that's clear for folks out there. We recommend that the individual completes 3 handouts per week over about 15 weeks. So if you can, distributing handouts like on a Monday, Wednesday, Friday with feedback in between, either self-run check-in style feedback or written on the documentation. And so you can kind of think about it as 30 or 45 sessions in total, plus going through the relapse prevention packet. So the modality, again, of feedback is flexible, but I would encourage folks to consider the client's abilities and the skill and their skills. So again, they may need to progress more slowly. They may need additional one-on-one support. Maybe there's a way to get a peer mentor involved in helping them work through the materials. The modules are intended to build from previous modules, so it's not a rolling admission kind of program. It's intended to, so you start with module 1, get kind of the foundation, and then the modules, they build from each other to create a coherent program. If you're sticking to the basic structure of providing handouts and giving feedback and exchanging information that way, this is our suggested one-on-one session structure, where you spend about a minute or 2 reviewing the handout, and then 2 or 3 minutes addressing questions, providing feedback on the previous handouts, going over goals, challenging aspects of criminalness, or encouraging them to engage and use some of those new coping skills that they're learning. And then summarizing the next handout and assign a date for completion. So again, this is kind of the bare bones of what we're suggesting, but certainly if your institution or the staff, there's more staff availability to go through these handouts in more depth, we certainly would encourage that as well. So, again, there are a number of other programs that are emerging for segregated individuals, but here are some ways in which we think that this particular program is beneficial. One, the counselor feedback, again, is flexible. It could be supplemented with out-of-cell individual or group sessions if that's available. It can be completed at a pace that's consistent with the client's abilities or needs, as I was talking about a little bit ago. If feasible, it could be done in a group setting. And I'm going to, hopefully we have some time, I know we're kind of running out of it quickly, but hopefully we have some time to talk about considerations for group setting and some different things to think about there. And if needed, the handouts could be selected on an as needed basis under certain circumstances. So if you have a short amount of time, I think, Bob and I, we are on the same page that, some treatment is probably better than no treatment, even if you maybe aren't able to get them through the entire program. But if you're going to be, pick and choose, it's recommended that they at least always complete module 1, because that's kind of the baseline, and they learn, or that's the foundational module where they learn some of the heuristics that are used throughout the program, and then make selections based on an assessment. So if this is somebody who is prone to self-harm or suicidal ideation, don't skip module 3. So being, making clinical judgments based on what the person's primary needs are. I'm going to skip over this. A lot of this is in the workbook, but there are some module content quiz rules in terms of passing scores and what you would do if somebody didn't pass, to help them, actually acquire the knowledge that they were supposed to acquire before they can move on to the next module. I'm going to quickly go through the module overview. So again, the module 1 is relatively brief. It's only 2 handouts, and it introduces people to these key program concepts. One is the circle of change, and the other is the mental traffic light. And then it also guides people through effective goal setting. And this is what the circle of change looks like. And it's basically helping them understand how thoughts are connected to their habits, or the way that they behave, and their environment. So key among this is the restrictive housing environment. And so talking with them about what kind of changes they have to make, and those changes are connected to their goals. This is the image of the mental traffic light. It's a heuristic used to help people identify whether their thoughts, habits, or environments are helpful or harmful to their goal. And for everybody, their overarching goal is to get out and stay out of segregation units, right? So we've got the green light, which is pro-social behavior, goal-oriented, up to the red light of this is a really high risk situation, and they've got to implement their coping skills now. Module 2, as I said, kind of introduces individuals to some coping skills to reduce some distress associated with the environment itself. So it includes things like sleep hygiene, coping with some sensory deprivation, negative mood. And in this module, there's also a weekly activity log, and again, meditation exercises that can be used beyond module 2. I'm not sure how well you can see this or not, and I may end up skipping through these because if we send you the copies of the slides, you'll have this. But this is an example of what a handout would look like, and so there's some text in here, and then also to make it interactive, there's different activities embedded within the papers or within the handouts, so that it's not just people reading materials, but they're actually writing down and reflecting and going through different types of activities within the handout. The self-injury and suicide ideation module educates clients about warning signs of suicide and self-harm, and introduces them to the interpersonal theory of suicide, the Joyner model that many people are probably familiar with. And this also includes a personal assessment of risk using the DHS, which is the Depression, Hopelessness, and Suicide Scale. It's a screener that was normed on correctional populations, and it's intended to show people what their risk level is and where they compare to other individuals. It also discusses the use of suicide as manipulation tactics. So probably all seen individuals who use suicidal threats to gain access or transfer or attention or whatever. And so we address some of those issues. And this is a handout on that particular issue. And so in here, the individual reads some text. There's a vignette that they're walked through, and then they're asked to think about the pros and cons of using suicidal intent as manipulation strategies. What do they get? What do people get from that? And what are the major consequences? And then how could they get what they wanted in a better way? Module 4 is understanding emotions. So this is kind of focused a lot on anger issues, but other emotions underlying anger. This includes a weekly aggression log to track anger triggering events and reactions. And here's an example handout here. And it goes through the conflict resolution model. It also has them sort of identify scenarios of passivity versus aggression versus assertiveness, and kind of educating people on what the difference is between being aggressive and being assertive, and how you can usually get more of what you want by being assertive than being aggressive. Okay, module 5 is more psychoeducational in terms of mental distress and criminalness. And so they learn about what these things are, what the risk factors are in general, as well as their specific symptoms. It's in this module. We also discuss stigma, both in terms of having a mental illness, but also seeking help for mental illness. And this one includes an assessment of the PICS, which is the Psychological Inventory of Criminal Thinking Styles. And I think this one is, in our experience so far in delivering this program, inmates really seem to like this because they can really identify with some of these criminal thinking styles, and you can show them which ways of thinking are more prevalent for them that they can focus on throughout the program. So this is an example of a handout looking at criminalness. What is it? Rating their own criminalness on this meter, and what types of behaviors they think would fall under criminalness. And so there's some other exercises here where they, kind of reflect on some of their own behaviors and what it means to engage in criminalness. Module 6 is taking a lot of that psychoeducation and then presenting individuals with actual coping skills for both mental health issues and some of the criminogenic factors. So this is where we'll see some emphasis on DBT type techniques for personality disorders. We also discuss the importance of medication compliance. Right, that is actually kind of at the crux of both mental illness and criminalness, because when people aren't complying with medications that they know are going to help them or avoid decompensation, that thought process of oh, I'm not taking my medications, I feel better, and kind of ignoring the responsibility of taking your medications can be discussed as a criminalness factor. And this one includes an automatic thought log, 4 additional relaxation techniques, a medication monitoring card. So this is a card that we developed for people so that they can track their symptoms and take this card with them, or side effects as well that they might be experiencing from their medication, so that they don't just, stop taking their medications or cheat their medications because they're making them feel worse, that they can take this card with them the next time they go see the psychiatrist or the medical professional in their institution. This one also, I like, this is about midway through, a little bit more than midway through the program. And so we have a progress checkpoint in here to highlight what things that they've done well so far. And, just to give people an opportunity to pat themselves on the back. This is a handout that, focuses on the need to stick with medications and why they take medications, why they should keep taking them, what are some side effects they could look out for, and what to do if they experience those side effects. Module 7 is the allies or more of our associates module. And again, this discusses the role of others and teaches individuals to establish relationships with less criminal peers. It also educates people about warning signs for grooming, victimization, consequences of gang membership, because again, individuals who often find themselves in segregation units are easily victimized if they have mental health issues, or may be there because they have gang affiliations. This module, this particular handout here is an example of a handout within this module talking about this RIT method of using social skills. So getting prepared, introducing yourself, how to establish talking points, and then how to exit a conversation. Module 8 is a little bit of a tricky one in terms of implementation, but this one focuses on clients' role and the importance of staff in maintaining institutional safety. So the goal of this particular module is to try to build some understanding and empathy towards staff and their need to prioritize safety within the institution. So it's to increase some rule compliance, respectful behavior towards staff. And this includes an assessment of the CSSM, which we saw earlier in the slide with the graphs. This is the criminal sentiment scale modified. And so it looks at things like attitudes towards the law and authority and things like that, just to see where people are at with that. And there's often some pushback with this particular module because inmates in segregation understandably don't always have the best dynamic or relationship with staff. And so when we're going through this module, we found that some pre-module preparation is helpful to mitigate some defensiveness, encourage an open mind. And it sometimes helps to sort of liken the prison environment to a casino, right? The house always wins. And if you don't, play it right, if you don't behave, you're the one who's going to keep getting in trouble. You're the one who's going to keep, you're the one who's not going to progress. And so sometimes you might have to swallow those feelings in order to, to do the things that you need to do to be in good favor and to get out. This is another example handout here that just kind of gives people an idea of how correctional staff are trained. What are they trained to prioritize? Understanding the impact of staff burnout and that there aren't always a lot of staffing resources or their staffing limitations that might explain why they don't get what they want when they want it. And so again, this is just to sort of help people navigate the sometimes aversive inmate to staff relations. And then finally, we have the roadmap to recovery, which again is the relapse prevention packet. And they prepare a letter highlighting their progress and commitment to change. They're asked to present this to people who are responsible for their release, or who would have some sort of say in whether they can go back to a lesser restrictive setting. And this is not the entire relapse prevention packet, but it's the first 2 pages. And so it basically highlights, it has people go through the main points of skill, or the main skill sets that they've learned throughout the program, and kind of jotting down, you can see here the quick reference. So here's what my goals are. Here's what my mental health diagnoses are. Here are my common criminal thinking styles. Here are some of the biggest warning signs for me, some of my biggest triggers. And this is a sample of what the progress letter looks like. And then finally, people get a completion certificate. And actually, they also get a module completion certificate as well now. So the e-resources for this program come with module completion certificates, as well as this end of treatment certificate. So you might all be wondering, well, does this program actually work? And we like to think that it's doing a decent job. So one, Bob talked about this earlier, is that the program is based on existing literature and existing best practices. So I think that's a good, a good way to start developing a program. So again, it dually targets the known criminogenic and psychiatric risk factors. It emphasizes behaviors that are more prevalent among segregated individuals. So for example, self-harm, some of the borderline and other personality traits. It directly speaks to challenges coping with a restricted environment. And that's not something that you often see in more general corrections-based programs. And it's structured, it's CBT informed, it's intensive, it uses simple learning heuristics and applicable examples throughout the program, which these are all things that we know work pretty well with correctional samples. And then earlier last year, we were able to publish a little bit of pilot data on this intervention, again, that was being run in the Missouri Department of Corrections. And we're gearing up to look at some updated data that includes about 80 participants with some follow-up information. And what we found was that the program was generally well accepted and feasible based on staff reports. And in terms of pre-post assessment, again, this is based on a pretty small sample size, but this is what we were seeing with this, is that individuals who completed the program had reduced emotional distress, and you can see the effect size there of 0.64. They had fewer criminal attitudes directly related to criminal activity. That was also coincidentally a similar effect size there. And we didn't see as big of improvements in terms of criminal thinking style. And so one of our thoughts was, we have a couple of different thoughts about that, is that one, there's some research now coming out that if you're familiar with criminal thinking, there tends to be 2 broad categories of criminal thinking: reactive and proactive. And a lot of the research is suggesting that programs like this are better at addressing the reactive criminal thinking, which is more the impulsive style of thinking, as opposed to proactive, which is more of a planned style of thinking. And so there may have been differences in terms of that. If they weren't improving on the proactive, that could have dragged down our results, or maybe there's other things that we need to do to make sure that we see changes in that regard. It could be due to the fact that criminal thinking is a little bit more ingrained. We might see changes the more time that goes by. So there's some more work to do in terms of the actual effectiveness of this program. But what we're seeing so far is that the results are promising, and certainly more data is needed. I would like to get into some additional considerations for the program. So as a disclaimer, what I want to go through here is certainly not an exhaustive list. I wanted to highlight some group format considerations, and then some considerations for special populations. Again, there are many other types of clients who may need their own specific considerations, and even the considerations that we provide are not exhaustive for those particular groups. So I just want you to keep in mind that that these considerations here are not exhaustive by any means. So I was lucky enough to get a little bit of funding from APF, I guess in 2019. And so we've been running this group or running Stepping Up, Stepping Out in a group format, actually on a female segregation unit. And so some of these suggestions are coming from the adaptation of the program for that setting. So if you're using it in a specific group, you may want to develop some rules that members must commit to. Bob's program, CLCO, has a list of group rules, and there's some in the clinician manual in terms of expectations that could be or that should be maybe adapted into a handout that can be given out to individuals just to make sure everybody's on board with the group rules. And maybe even talking about some brief conflict resolution skills at the beginning of the program so that you can fall back on those skills when people are not following the group rules or they're engaging in crosstalk and things like that. Integrating visual and physical activities as permitted, and realize that on these units, the mobility of individuals may not be as flexible or permissible. And again, a lot of these are, I'm sure people who have done group interventions before would understand, what's needed to make for a successful group here. But things like whiteboards, markers, any kind of notepads, role plays or acting out scenarios is really helpful. My student who I've been supervising in doing this in a group format came up with a few activities on the fly. So in one of our modules, we have an exercise, a mindfulness-based exercise on dropping the rope. And so she had clients act this out as if they were playing a tug of war with their own thoughts or emotions that seemed to pan out pretty well. Or when discussing some of the criminogenic risk factors, she had them sort of create a human scale on the floor, and then the client stood in place to rate where that risk factor would be for them. And so it kind of led to this group discussion and a more realistic understanding of what some of their risk factors were. So maybe needing to get a little bit creative in terms of what's available or what you're able to do in an environment that's restricted. Co-facilitators, we also, in adapting this for that unit, we came up with a suggested schedule for a 24-week period of time. So if anybody is interested or would like to do this in a group format, we can share that schedule that we came up with for that. Considerations for people with mental illness, emphasizing the responsibility of coping and seeking help when needed. So sometimes when people have more serious mental illness, their coping skills or their lack of engagement in coping skills may be a sign of decompensation, or it could be a sign of some of that criminal thinking. So blaming others for their illness, refusing or taking medications. And so emphasizing that while they're not responsible for the fact that they have a mental illness, they are responsible for implementing coping skills, asking for help when needed, and doing the things that they need to do. Spending extra time on distress tolerance might be helpful. This is some work that my student is doing for his dissertation, and actually looking again at Bob's CLCO program. And what he found was that those who reported having a psychotic spectrum disorder were more likely to be in a group that didn't benefit as much from treatment. And so because Stepping Up, Stepping Out is based on that same paradigm, it may not be effective by itself. And so making sure that medication compliance is prioritized, and also advocating for thorough psychiatric consultation and consistent medication administration. Sometimes, clients have, especially those who are in segregated units, might have difficulty getting in contact with the psychiatrist or, nurse practitioner, whoever's overseeing their medications. And so it might be on us as psychologists to help them advocate for those needs. And if possible, determine whether that person could be housed elsewhere or in a more therapeutic environment.
On those lines, a question that's come up a couple times in the Q&A and in the chat is individuals with lower intellectual functioning and or cognitive impairments. Can you address the reading level and our strategies for individuals with lower cognitive functioning?
Yeah, actually, that was my next slide, but I know we're running out of time. So I'll breeze through it and then I'll get to that one. And then we can maybe just skip to like our concluding remarks and open it up for any remaining questions. Does that sound like a plan? Okay.
Yeah, I just wanted to make sure we didn't miss that one.
Okay, yeah, that's a really good one. So again, we've been fortunate to be able to test out stepping up, stepping out with a group of women who are in a segregated section of the prison. And so a lot of these recommendations or considerations are coming from our work with them. So importantly, research, at least so far, suggests that the R&R model that we talked about earlier translates relatively well to women, that women seem to have a lot of the same, most of the same criminogenic risk factors that men do. And again, stepping up, stepping out is not male-centric as a lot of programs are. Oops, got my animations messed up here. But importantly, women, as many of you may be working with women primarily, and you'll see that they have a higher prevalence of certain symptoms or experiences than men do. So for example, trauma exposure, as well as PTSD. So depending on the studies that you look at, some have estimated that as high as 90% of incarcerated women have been exposed to interpersonal violence. They also have, or at least are diagnosed more often with borderline traits. They tend to have more adverse social conditions that they're experiencing. And so even though the R&R model is pretty relatively, at least again, so far based on the research, gender neutral, we could think of gender responsive care as improving the responsivity to stepping up, stepping out. So this is for women, this might be, balancing responsibility taking without criminalizing or victim blaming them for being in traumatic situations or being the victim of trauma. And so helping women evaluate decision points and what, if any, alternative choices were available to them at the time. Something that might come up in module 8 in particular, which is the us versus them module, is acknowledging some of the inherent power differential that could be re-traumatizing, especially if many of the correctional officers are males working on that unit. Women also often struggle more with getting certain basic needs met. And so, for example, lack of access to feminine hygiene products, for example, may be a salient stressor for them that we as women may not, we may take for granted. And that may be something that is a more pressing distressor for them than what we might be inclined to focus on. And then for module 7 in particular, focusing on manipulative interpersonal romantic relationships. So women tend to have less gang involvement, but are more involved in, sort of these romantic relationships or having girlfriends on the unit. And so they may be involved in manipulative relationships, a lot of gaslighting and things like that. Trauma is also very important, of course. And so we're kind of in the process of developing a trauma-focused module for stepping up, stepping out, but it's more of a psychoeducational module because SEG may not be the best place to really go in depth with trauma because there's a lot of noise. There's, potential for increased hypervigilance and things like that. So through the program, you can encourage women to seek out ways to work more explicitly on trauma recovery once they get back into the general population. And the other considerations might be to introduce some of those DBT skills a little earlier in the program and maybe build some of those other issues into goal setting, right? So how can they better ask for those hygiene products that they need as opposed to becoming assaultive or aggressive when those needs arise. Okay, and then somebody asked about cognitive impairment. And so here's a couple considerations. So stepping up, stepping out is a bit higher in terms of the reading level. I think we've estimated at about a 9th grade reading level. And again, I think a lot of that is due to the fact that there are a lot of psychological terms within the program. There's terms like segregation, which are higher reading level. And again, we try to mitigate some of that by providing a glossary of terms for some of those more complicated phrases or terms that we use often in psychology. So these are some accommodations or modifications that are likely to be needed. It's also possible that stepping up, stepping out is not going to be, if somebody is very severely cognitively impaired, we haven't tested outcomes on that particular population, and so it may not be the best program for them. But some accommodations or modifications that you might consider would be one to include more individual time with counselors, if you can pull them out of the cell and do some one-on-one discussion with them, perhaps longer administration times. A colleague of mine who works primarily with individuals who have intellectual or developmental disabilities always puts it in terms of more reps. So more repetition, having to repeat yourself, or having to find other ways to simplify the language so that they can translate some of these coping skills and new ways of thinking to be more automatic for them. So thinking about, again, more reps. How can you help this person acquire the knowledge and the skills? I mentioned earlier use of a peer support specialist or a mentor, maybe somebody who can come in, somebody who's known to be a model inmate or somebody who successfully went through the program to be able to provide some additional assistance or walk them through the program a little bit more at their pace. Other suggestions might be to create reminder cards, other strategies to break up the content. And then in terms of modules, it might come up in module 7, talking about the associations and, identifying grooming and when other people are engaging in grooming behavior. So spending more time on that module and really focusing on their own risk factors for victimization and, helping them overcome some of that acquiescence that people with cognitive impairment often have, the sort of yes and agreeing to things, and maybe spending more time on that particular module, helping them recognize when they are being victimized or when they are being targeted and how to manage that or seek help for that. Okay, so we were gonna go through some assessment of outcomes. And I mentioned some of the assessments that come with the program that are actually used both in terms of providing therapeutic feedback, but also can be used to track the individual's progress. So the DHS, the PICS, this CSSM are 3 that we recommend, or actually are more so required, I would say, because they are integrated in the program. But those 3 can be administered at the beginning and at the end of treatment. And you can use their post or pre-treatment scores to give feedback during the program, and their post-treatment scores to show them the extent of improvement or what other areas they still need to continue working on. So the one thing I do just want to say very quickly about this is that I would encourage everyone to consider all of the work that you're doing to be empirical work. So to truly inform best practices, come to view everything you do program-wise as an empirical effort. I had another quick polling question, so I will launch it and maybe you can respond as I'm talking here. But the question is, does your institution or hospital routinely evaluate programs or interventions? And so the options are yes, sometimes, or no. So I'll launch that poll as I'm talking if you want to put in your responses there. But again, treating your program almost like a research project. And again, resources might be limited in your facility, but often, people like Bob or myself as academic collaborators are often very interested in helping with program evaluation efforts. And encouraging, institutions or wherever you're working to publish and present those findings. As we talked about earlier, segregation is a really hot topic. People want to learn about it. People want to know that you're making an effort to make changes, even if they're incremental changes. So I hope that, whatever program you adopt, whether it is stepping up, stepping out, or some other program, that you treat it like a research project and you look to see if you're getting the outcomes that you're expecting. In terms of the poll, we have a pretty even split here. So most of you said that you sometimes evaluate programs, and 28% said that you did not, and about 24% said that you did. So certainly some room there to increase program evaluation efforts. Oops. Okay, for the sake of time, I'm going to skip to our final thoughts. And basically what I'm skipping over are things that I think you can reference when we are able to distribute copies of the slides. So don't feel like you're missing out on anything too. Well, I don't want to say it's not integral, but not anything that you couldn't, not any information that you couldn't glean on your own. As far as final remarks here, we've talked about the need for tailored treatment, but certainly that's not the only thing we need to do. There's lots of other ways in which we can improve the current situation. One of which is to instill hope of release to the general population. If people are putting forth their best effort and they're engaging in programs, there should be a high likelihood that they'll be able to go back at least to a lesser restrictive alternative. So maybe it's not, population, but maybe it's the next level down, or there should be an opportunity for them to work towards release back into the general population. Implementing more immediate behavioral rewards to a point, right? Of course, we don't want people engaging in programming just for the sake of benefits, but if we can increase out of cell time, the more they're engaging in program or have access to certain commissary items that are popular or something to help supplement, they get completion certificates, but it would be nice to incrementally add some other kind of behavioral rewards along with that. We know that people in general have faster improvements when rewards are given more proximally to the desired behavior. Supplementing with other services whenever available. So to the extent possible, art therapy or other kinds of activities that they could be involved in, educational services that might be available. Providing transitional support, and again, pairing that with increased out of cell time as available and feasible. And then we can't just expect the individual themselves to change. We need to work to improve the institutional environment as well, making sure at baseline that conditions are clean and humane, and training staff again on signs and symptoms of mental health, such that they're treating mental illness as mental illness and not as something that is requiring punitive sanction. And as I mentioned earlier, continually evaluating outcomes. And as again, the final note here, I think as psychologists or mental health providers, there may be some of you out there who aren't psychologists per se, but I think we have, as providers, we have an obligation to advocate for these changes and ensure that our clients are treated as humanely and justly as possible. So, and Bob and my contact information will be on these slides as well. So are there any questions that we can get into? I apologize that we went through the last bit of it a little bit more quickly than we had planned. But
just so you know, Ashley, I've been responding to questions pretty much as they've come up, both in the chat and the Q&A. But for all of you out there, any final questions, thoughts that you have?
we should have placed a bet, Bob, because Bob thought we would have plenty of time and I thought we were going to run out of time. I should have bet on that one. Anything else? I'm going to actually stop sharing my screen here for a minute so that I can pull up the CE link. Yeah, if anybody, and there's a question about implementing the program, if people want to implement the program, they're certainly more than welcome to contact me or Bob. I think the program is available for purchase through Rutledge, and I think it's also available on Amazon. I apologize for.
I already got it.
Oh, you got it. Okay, you're quicker than me. I don't know where it went. So we'll leave that. Oh, you got the book. I thought you meant the CE link. I apologize. I thought I had it right in front of me, and I don't.
Ashley, what's your email again? Just tell me.
My email?
Yeah.
ASA. Yeah, I'll put it in.
Oh, I got it actually.
Beth, I'm wondering if you're if you're listening in at all. All right, got it. Sorry. I don't know where it left me at some point. Okay, I'm going to put the CE link in the chat box for everyone. And again, if you don't click on this or don't get the link before we close out for the day, there'll be an email tomorrow, I believe, with the link. I'll give folks a minute to click on that. Any other, I don't know, any other final comments, questions from anybody? Oh, Beth put it in the Q&A box as well. Thank you. All right, well, that's about our time. Again, we'll get the slides out to everybody. And if there are any questions, feel free to email either one of us. And we really appreciate your time and attendance today, and also your participation and engagement. It was really helpful such that we weren't just talking to ourselves.
Ashley, this is actually probably more for Beth, but the links are blocked by somebody's system. This is a question for an issue for Dr. Tosada. Beth, is there another way that they can access the links to get to complete the evaluation form and get the certificate? All right, if you need access to the links or the evaluation form or the certificate, Beth can send you that via email if you email her. Beth, I don't know if everybody has your email or not. Maybe you want to type that into the chat.
I believe there's also going to be an automatically generated email tomorrow with those links, but I guess if they're not working for folks, it may not be resolved by that.
Thank you, Beth. All right, thank you all.
All right, thanks everybody. Wait, there were two. All right, see you later, Bob.
I'm gonna hang on just for a minute to see if there's any other things here in the chat. You wanna call and debrief or anything,
Sure.
or move on?
I feel bad because I while you were talking there for a minute, I checked my email, and a lot of people, not a lot, but I had quite a few emails of people who are having trouble logging in or couldn't get the password or the passcode
Really?
to work or whatever. So would have been helpful for.
Oh, that's disappointing.
Yeah, it was kind of too late to, I wasn't quite sure how to help at that point.
Yeah, yeah. Doesn't look like there's going to be any more questions. All right. I think we can exit out.
I'm gonna maybe, since there's 77 people on, I wonder if people are still getting the link. All right, people are trickling off. Okay.
All right. We'll talk later.
Okay.
All right.
Bye, everybody.
Bye.